Welcome. Welcome to Pilates Applications for Health Conditions. This is the monthly webinar series sponsored by Handspring Publishing in celebration of the book, the forthcoming book in 2021, Pilates Applications for Health Conditions, co-edited by Madeline Black and Elizabeth Larkham. Our guest today is Christine Egan, Pediatric Physical Therapist. Before Madeline introduces Christine, and they've been colleagues for decades, let's take a look at a slide that explains what you can expect during today's webinar. The webinar is being recorded on YouTube. The chat is on, so please do say hello and tell us where you're joining from. We welcome your questions, and please submit your questions using the Q&A button, because the first questions that that Christine will answer will be those coming from the Q&A area, and then as time allows, she'll also respond to your comments in the chat. The webinar will comprise roughly 45 minutes of mixed discussion and presentation. There will also be some opportunity for movement practice on your mat. The last 15 minutes of the webinar will be devoted to Christine Egan answering your questions. However, if there are additional requests for information, then Christine is prepared to go 10 minutes over the hour. At the 9 o'clock hour, we'll post a summary slide that explains how you can get in touch with Christine Egan if you have requests for individual consultations regarding your own practice or your own experiences. So we'll just bring your attention to the disclaimer that this discussion is for information purposes only, not for medical advice. And now over to Madeline to introduce Christine.
It's with great pleasure to introduce Christine to all of you. As Elizabeth said, we've been colleagues for decades, and I've always admired Christine's passion and her clarity and her knowledge and the gifts she brings, especially children, for their well-being. Christine is a pediatric physical therapist with 40 years of experience in pediatric rehabilitation. She was educated at Hunter College of New York City, and Christine spent the first decade of her career working and learning from some of the best therapists in North America. Her training includes neurodevelopment treatment, NDT, orthotic evaluation, casting and fitting, the Galileo whole body vibration therapy, TES, the therapeutic electric stimulation training, kinesiotape, and a host of manual techniques, including cranial sacral therapy. She began doing Pilates over 25 years ago to maintain her strength of her own body. And in 1992, she was practicing at St. Francis Hospital, where Elizabeth was working, in San Francisco. And she did her Pilates teacher training in 1999 to 2000 with me and the ITT Pilates program at a body of work in San Francisco. Now, through the years, she's modified and applied the principles of Pilates exercises to address the sensory motor needs of children with orthopedic and neuromuscular disorders. And through the years, Christine's been a lifelong learner, and she continues to develop her strength and her skills, and she designs programs for children that improve the overall quality of their life and for their families. Christine is currently the owner and director of the Christine Egan Physical Therapy, a pediatric PT private practice in Marin County, California, serving the children and their families in the Greater Bay Area. And most recently, Christine published a series of blog posts entitled Local Heroes. And it features 12 of her former clients and the challenges and the successes that they've had. So I'd like to share a video of Christine's practice Christine, welcome. And could you say a few words about the little video clip we're about to see?
Yes, thank you, Madeline, for that wonderful introduction. It has been a great honor for me to work with you over the years, and this is just super fun that we get to do this today. This short video basically tells you about the myriad of things that we do at the clinic. It includes Pilates, but it also has other modalities in it. And it expresses my basic philosophy of how I approach pediatric physical therapy.
And then the waiver.
Oh, and all the images that you see in the video and all the photographs and other images that are used in the webinar today, I have gotten parental releases to use photographs and videos of their children. I would not use any photographs that I hadn't gotten a release for.
Christine Egan's physical therapy office is located in beautiful downtown Point San Quentin Village, California. Our office is centrally located in Marin County and is easily reached from the East Bay, San Francisco, and the North Bay. Our office is a cozy converted horse stable. It's small, it's well located, and has a lot of fun stuff in it. Over the years, we've acquired a wide range of therapy equipment. This allows us to treat a wide range of conditions with children from the age of 3 weeks up to college age. The core of our treatment is neurodevelopmental therapy. This requires a strong working knowledge of a child's normal development. We use a dynamic approach to elicit typical motor skills and develop postural control. Much of the work we do is to apply concepts that are basic to many forms of movement. By analyzing what your child's needs are, we can tailor a program to meet those specific needs. Using a hands-on approach and a learn-by-doing process, we are teaching rudimentary movement skills, not tasks. Then your child will develop by connecting and building on those skills until they can accomplish their goals. What sets our therapists at Christine Egan Physical Therapy apart is an ability to understand and evaluate the underlying problem. If you don't understand the underlying problem, how can you have a solution? We do everything we can to help your child achieve their gross motor goals, traditional and non-traditional approaches. We are hoping to make your child function at their maximum capacity. Some of the other methodologies we offer are biofeedback, Pilates for children, designing compression garments, orthotic management, kinesiotaping, postural assessment, core strengthening programs, balance and coordination activities, treadmill training, designing home programs, and manual therapy. We take our work seriously here at Christine Egan Physical Therapy and feel we offer the best quality and cutting-edge therapeutic techniques available. Here is some equipment that's unique to our office. We use the Lightgate unit to help children who cannot stand learn how to walk and take steps. This program works very well for children with Down syndrome. About 15 years ago, we pioneered the use of Pilates with children. We find it helps to keep the kids interested and makes them feel important. Our newest piece of equipment is the Universal Exercise Unit. This piece of equipment uses pulleys, ropes, and weights to help children of all ages complete strength training exercises, similar to what an adult would do in a gym. Here, our therapist helps the child improve their static and dynamic balance both before and after they learn to walk. The cage, as it's sometimes called, allows for many options for providing vestibular stimulation and supported postures against gravity. Whatever path your child is on, we can help them achieve their best and allow them the freedom of movement they deserve.
Oh my God, I just want to play in that cage.
Yeah, there's lots of fun things you can do with that too.
It's really nice. So Christine, can you tell us how you got drawn into doing pediatric physical therapy?
I hadn't planned on being a pediatric therapist when I went, started physical therapy school, but I did an internship, a summer internship with a person who was in a private practice, and I could see the flexibility that she had. She could offer a lot of different modalities and the effect that it had on children. And part of working with children is preventing further issues. So to me, the earlier that you can treat an issue, the more effective your treatment's going to be, and you're going to avoid some long-term effects of any kind of physical or neuromuscular disorder. So prevention.
Most people, most parents, aren't aware of early. How do you diagnose? How does someone come to you? I mean, how does a parent notice that something's not quite right?
Well, most of my referrals come from a doctor, but often it is the parent. I'd say 50-50. The doctor notices something or the parent. Often the parents, I trust what parents observe because they're with the child 24/7. And as a mother or as a father, I think you inherently know when something's wrong. So I just respect what they're bringing to me, their observations, and we use that as the key to recommending what might be necessary, be it a short-term intervention or is it a bigger long-term problem. And then the diagnosis often comes from a specialist. It could be a child neurologist or an orthopedist or a pediatrician or some other specialist in the field of pediatrics.
Yeah, in our conversation, you mentioned what stuck out to me is how pediatric physical therapy is really based in neurology. Could you speak a little bit about that?
Well, most of what I see is developmental issues. And in infants, the development that you see, the progression of development, has to do with the maturation of the nervous system. So as the child is born, they come into gravity and they start moving through these developmental sequences. If they're not moving appropriately, what we might call atypical development, that's how you start to see something's not quite right. Like they're not meeting their milestones, or there's some kind of abnormal body posture, or they can't move very well. They may have a paucity of movement. So all of that is reflective of what's going on with the nervous system. And the nervous system, as we know, is attached to the muscular system, and the bones are formed by muscle forces of the muscles and moving through gravity. So it's all interconnected, but the basis of it is the nervous system.
So one of your studies that you've done and you still use to this day is the neurodevelopment technique. Can you speak about what the history about that and your experience with it?
Yes, so neurodevelopmental treatment was started by a couple, German couple. She was a physical therapist and he was a neurophysiologist. They escaped Germany before World War II, and they set up a center in London, which is called the Bobath Center. So in Europe, it's known as the Bobath method. Here we call it neurodevelopmental treatment, and it's an internationally known form of both pediatric and adult stroke treatment. So it's totally, where the neurology, is still foremost in our minds. But the basis of the treatment is to create proximal stability so you can have improved distal control. So and that's really a gold standard for most pediatric therapists, that you go through an 8-week training. The training consists initially of learning typical development, because if you don't know what to expect, what normal is, then you wouldn't really know what abnormal is. And then dealing with problem solving, doing movement analysis, and assessing postural control is all part of the education in neurodevelopmental treatment.
So a lot of our audience may not really know clearly. We know there's a developmental stages, as we're growing. Could you speak and share with us what that development is that we want to see, the more normal or typical?
Well, in an infant, and we're going to see some slides of different children, infants and other children, but initially what you're looking for in an infant is symmetry. So symmetry is the base, also midline control, because we operate around a central axis. So all movement occurs on that axis. And, if you see someone who has an asymmetrical head, or the arms and legs are not moving the way they should, that's your first sign. But in my mind, any kind of asymmetry is a red flag, that something is not correct. Everything should basically move fairly symmetrically.
Can you describe to us just, from when a baby is born, what that development is?
So
what are some of the movements that?
Well, initially, and I'm going to demonstrate this on the mat too. Initially, a baby is born with a lot of flexion because they're in utero. And as they are born into gravity, you start coming out of that physiological flexion into extension. And that is done in the prone position, which is on the stomach. And from there, you start to learn how to go into extension, like you use back extensors to lift yourself up off the ground. And that is a very primitive response. It's in our makeup from when we were, little apes and needed to lift our heads up. And from there, as the head lifts, the weight shifts down through the body toward the tail. We call it a caudal weight shift. And that's really important because as the center of gravity shifts from the chest down to the pelvic region, you free up the head, the shoulder girdle, and the arms to manipulate more and start the weight shifting process. So you have a caudal weight shift, which is more in the sagittal plane for flexion and extension. And that allows you, once you've mastered that, then you go into more lateral movement. And the third, level of movement is more rotational components of movements that allow for more triplanar complex movements.
That's super interesting. And when you, so you were studying this prior to your exposure to Pilates.
Yeah.
So how did you see when you started just even working out yourself in Pilates before you decided to do a teacher training? How did you connect the dots of what you had seen in this development patterning with Pilates?
When I started doing my own Pilates and just going through the movements myself, I physically was aware of how much trunk control Pilates required in order to do it properly. And that totally meshed with the NDT concept of what we called trunk control, which people now call core stability, or I might even call it core postural control, or anything having to do with stability of the proximal structures, which I would include like the whole torso and the head. And in order to have controlled movement of the extremities, you needed to have this postural control. So I was laying on the mat doing my Pilates thinking there must be a way I can use this with the kids. And then slowly I just started experimenting with mat exercises with the kids, which I still do. I still use some very, very basic mat exercises as my primary home program for strengthening the core in children from anywhere from 3 to 23. So it meshed, Pilates meshed perfectly with what I was already doing. And I was able to kind of bring the concepts of both of them together.
Christine, would you speak about the kinds of modifications that you needed to make to the Pilates exercises in order to make them appropriate for the children in your practice?
In terms of mat exercises, often so children don't do anything without a motivation. So because they don't have abstract reasoning, we as adults, we know I'm going to do this exercise because I'm going to have a benefit at the end. Children don't operate that way. So there needs to be something in order for them to do. So let's say if, meatball is a really popular exercise because they understand meatball. They know what a meatball is. But even,
so is that rolling? Is that rolling like a ball?
Rolling like a ball. Yeah. And even things let's say if you're having them reach for their knees, doing a basic, a modified 100 or a crunch of some sort, often I will have to put a pillow under their head because they can't lift the head from zero. I have to put the head in partial flexion in order for them to initiate the movement, because I want them to initiate it with that cervical flexion. I don't want them to just push into the floor and do it. So I observe how they do it on their own, and then I make certain modifications for them to do it properly or with better alignment and better activation.
And like early 2000 or around 2000, you started working on the Pilates apparatus with the children. And
Yes.
you went to Balanced Body. Could you share with us your innovation that a lot of people won't know because we all use it all the time?
Sure. So when I started with Matt, then I saw that I needed to have the equipment because I could do so much more with it. And also it was going to help me in my own practice because it supports the child's body. So if you're familiar, I'm sure you are, with what I would call a standard studio reformer, the foot bar on there was never going to work for what I needed. So I went to Dave Littman at Balanced Body, and he came up with this, which was one of the first adjustable foot bars. So if you can see, that has made the distance from the head to the feet much shorter. So I often have the foot bar in this position. This is where I often keep it. And then we came up with things like shoulder blocks and things like that. But what I've ended up with, the shoulder blocks were a bit awkward. I happen to use like firm foam. And then on top of that, I'll put maybe like some kind of cervical roll soft pillow. So the child's head is here and their bum ends up somewhere down here. I brought this out because this is an interesting tool I use also. I use this a lot for sitting on the box because this wedge can help position the pelvis so that it can move more freely. But that's just a fun little thing. And then one of my other tricks is we came up with a jump board. I use this quite frequently. And it has this target area on it because often the kids, their feet are just moving all over the place. And for certain kids who have, serious cerebral palsy and things like that, we couldn't create a closed chain unless I had fixed their foot to the footboard. So it's more of a therapy tool. It's a sandal where we actually attach the feet to create closed chain movement with the jump board. So that's how they would do what we would call footwork, but it's more for them about learning mid-range control of hip and knee flexion with the foot fixed. But we use this a lot because kids love to jump, and I get a lot of mileage out of that footboard.
It's wonderful.
Jump board, rather.
Yeah. So I'd like for you to share with us, because I was so moved when you started posting your blog posts about your local heroes. And as I read the post and saw the amazing transformation of the children, it's really quite special. Before we kind of take a look at a local hero of yours, could you speak a little bit about the cognitive and emotional changes that you see with your heroes?
Mm-hmm. Well, the heroes are, many of those children I've seen over a course of years. So we know each other very well. And, when I first start working with people, often I'll see them at least once, maybe twice a week to kind of set up our plan. But each one is special. Each one brings to it their own personality. And I try to work with their strengths. So when I do an assessment, I'm looking not only for what are the problems, but what are the strengths. And I start by meeting that child where they are, and then we move together. So I'm always trying to key into what's going to make this person want to do the next thing. So that's, the essence of how I start with somebody. But these local heroes, it's been great for me too. It's great for me to reflect back on all the things that they did to get to this point that they're at right now.
Okay, let's
Christine,
take a look.
to follow up on that point, in your teamwork with the physicians, the pediatricians, et cetera, do you get information, feedback from the academic aspects of your patients? as to how they do in their cognitive work, their academic work in school, or their self-esteem?
I will get more of that information from parents who will tell me about, something that they may be able to do that they haven't been able to do before. Often it comes in the form of them finding something that they enjoy doing, the child enjoys doing, like they may join a singing group or a drama group or put themselves out in some way that requires you to be confident in what you're doing and be able to move in certain ways and function in certain ways that they may not have had the confidence to do before. But they are growing into who they are and, taking advantage of the movements that they're learning and, all their physical accomplishments.
Okay, let's take a look at
feedback from, academics, as we might say. More of it is anecdotal through parents. And parents come to me with a lot of the various problems, if something's not right at school or the sports team or whatever, we try to come together and come up with a solution.
Wonderful. Let's take a look.
So this is my blog page that has all the different former clients listed on there. And it's interesting to read. Some of them they're just fascinating people in and of themselves. And you get to read a little bit about what they did. And we're going to focus on Caroline. So this is Caroline. She, to look at her, you would never know that she has cerebral palsy. She was, I started working with her when she was about 2. She was diagnosed with cerebral palsy at about 18 months of age. And I followed her on and off through the years. We did a lot more in the beginning. And we have some video of Caroline that we'd like to show. So Caroline the title of her Local Heroes article is True Grit. And this kid loves working out. I mean, she just loves the physical challenge of it. She likes the resistance she feels and the strength in her body. And you can see that is not a typical looking child with a young adult. She's a teenager now with cerebral palsy. So this is a short video of Caroline. She's about 4 in this video. And what strikes me is that you can see actually how her posture is quite good for a 4-year-old on a reformer. She does have some additional aids. If you look at the blue, looks like shorts. That's a compression garment that we use to give her more proprioceptive input into her body. And she's wearing orthotics, which keep her feet and ankles aligned. And part of what I think in general, what Pilates has to offer children is the proprioceptive input that it's very difficult to find in any other form of treatment that I've encountered.
You don't let the legs wobble though.
So here she is. After she's had very extensive surgery to decrease the spasticity in her legs. So we work a lot on hip extension. Here we're doing lunges in NDT and other forms of pediatric physical therapy. We're always trying to dissociate the legs because the legs often move together rather than independently. This is one of my favorite positions because you have to hold the leg in abduction the entire time, which is also a difficult movement for them. Here we're working on having her extend her knee without internally rotating her femur, which is very, very difficult. So I moved her heel onto the bar in order to take out any foot movement that might influence the internal rotation of her hip. And she's doing really well. She's working very hard there. This is one of my favorite shots of her because Caroline is one of the few individuals I've worked with who has cerebral palsy who has independent pelvic control, which she worked very hard to achieve. And I think a lot of the sensory and proprioceptive input allowed her to feel what was going on there. And then we're just honing it even a little more. You can see how hard it is just to go down on a forearm to really get her pelvis tilting forward. But she's She's amazing. And this video is made by her mom as I'm teaching the parent what to do with her at home, because she had bought an Allegro to use at home, which she still uses. That video was taken about 4 years ago. And she still has a very extensive workout routine.
Fantastic.
Christine, when Madeline invited you to be a contributing author to create a case report for the forthcoming book, Pilates for Health Conditions, could you talk about how you chose which of your patients to be the case report, and also explain if you had to make any modifications to the assessment?
Well, when Madeline approached me, I first started talking about someone like Caroline who has cerebral palsy, but that doesn't encompass a wide range of the normal population, typical population. That's more of a disability rather than someone who's in the general population who could benefit from Pilates and who is a child or an adolescent. So we decided I decided to choose Taylor, who is now 12 and a half years old. And I have a lot of long-term relationships with my patients, but Taylor initially came to our practice to treat a condition called torticollis. So that was the initial, experience we had with her. I do have some pictures of torticollis to show you. Oh, here we go. So this is a baby this is someone I've seen recently. This is a 5-week-old baby. So the condition that is called torticollis, that literally means twisted neck, is that it's a shortening of the sternocleidomastoid. So the shortening often can happen in utero, especially if the baby descends early and they're in a headstand for an extended period of time. Or it's also very common in twins or multiple births where there's just not enough room and everybody's just, vying for space in there. So what happens when the sternocleidomastoid is shortened is that the same side ear comes to the shoulder. You can also have involvement of the shoulder where the shoulder starts to elevate, as well as rotation to the opposite side, because the sternocleidomastoid runs on a diagonal. So when you have shortening, you have same side flexion and counter rotation. So this is a 5-week-old little guy. And the next photo is him after I treated him, where he's in midline and he looks much more symmetrical. So what happened with Taylor, we'll go to Taylor, is we resolved the neck issue, but over time, she still had residual lateral flexion issues with her head. At about 5 years old, mom noticed that she was kind of creeping back into that position. They brought her to traditional physical therapy where they worked on elongating her tissue and strengthening the opposite side and giving her more range of motion, things like that, that never totally allowed this muscle to fully lengthen. So she actually had a surgical release of that right side sternocleidomastoid. And then that resolved, and mom, years later, about 2 years ago, when she was about 10, brought her in because she had associated biomechanical issues. So like when you have that residual shortening, often the whole side is shortened. So this feeds into, biotensegrity and all the other things that we know about muscles and soft tissue. But you end up with like a lot of asymmetries of flexion, then you have counter rotation. She ended up, because of the shortening on the side, an asymmetrical leg length. So there are lots of different things to deal with, and then the compensations that come in to adapt to those biomechanical issues. So I thought Taylor would be a perfect person to do a case study on. And she was very willing to do it. We didn't know what her response was going to be when I asked her, because she's a typical 12-year-old girl who rolls her eyes every time you ask her something. But this time she said, yes, I definitely want to do it. I want to help people. So we were all pleasantly surprised that Taylor was completely on board, and she was an amazing subject to use for a case study. So as you can see, she's very compliant. She's able to follow directions, and she also had a lot of benefit from the proprioceptive input that she was receiving from the machine. Because I think underlying, she's more on the hypotonic or low muscle tone, hyper flexible, like having too much flexibility, which, you know, there's a beautiful, what we call just right moment where you have a balance of flexion extension. You have just the right amount of stability and flexibility. And that's something that I can easily work with using Pilates, because it is such a precise, you need to have a precise outcome in order to do the exercise properly. But she loved it. And we listened to Billie Eilish the entire time that she was doing it. So we had fun. And luckily I have use of the box, which she did great, because we needed to work a lot on lengthening the lateral aspect of her body. And so we did a lot of work with that. And interestingly,
Christine, maybe at this time you could also speak about what you've explained to Madeline and me, is that children are not little adults, and that the approach you take with your patients has to be child specific or teenage specific.
Yes. Yes, children are definitely not little adults. They do not function the way adults do. And I think the important thing is really getting a feel for where they're at. So meeting them on their level. And that means like playing with them. So much of what I have to do is make things into a game or make it into an activity that they understand. Or as a young adult, appealing to where their interests lie. Like Taylor wanted to, you know, have the right posture. She didn't want, you know, she's coming into her teen years and becoming more aware of her own body. So it's quite individual. And even the activities I do, the exercises, what we do, it's totally to the individual. There's no standard protocol for what I do in terms of Pilates with any of my clients. I am problem solving in the moment. What worked, what didn't work, make it more springs, less springs, change it, back it up, make it easier. And I often start with where they're at so that they can be successful. I'm not trying to get them to do things they can't do. I want them to do something they can do, and they see that they have accomplished something, and then we move it into more difficult realms. So often the form may not look great, but they're learning how to get to the next place.
All right, so I'm really fascinated by our conversations, Christine, and one of the things that really stuck with me was the whole concept of feeling the flexor side of your body on the floor to actually facilitate extension. Like we think of extension, we only think of like the back muscles doing extension, but if you could show us now the movements and then describe that. It's a postural reflex that we have, that we still have even as adults.
Yes.
Right.
I'm going to move over to the mat so I can demonstrate. So I'm going to move through what is called a developmental progression. So when a baby's born, they're in physiological flexion. So they're kind of like balled up. And even when so gravity starts letting them kind of extend out into a prone position. And I will back up a little bit, because a lot of the issues I see now are because babies do not spend a lot of time in this position now, since back to sleep occurred in 1992. So that brings us back to the whole torticollis thing, but it's all connected. So what happens when you're here, you're even getting weight bearing through the cheeks and the oral motor structures that aid in eating and talking and using your mouth for, chewing and swallowing and speaking. But what happens when I extend is I'm using my back extensors, but I'm also elongating and weight bearing on the flexor surface of my body. That creates activation. And that is one of the primary concepts of neurodevelopmental treatment, is muscles activate by weight bearing on them and lengthening them. So this is the prime example of weight bearing and elongation of the flexor side. So what happens, as I mentioned before, your center of gravity starts to shift as you shift back. I'll move a little bit this way. So you can see that my center of gravity is now located down around my lumbar spine, my pelvic area. So if you keep pushing back, you go into hands and knees. And this is a position that, you know, you'll often see babies rocking in, and that's sagittal plane motion. And then they start to reach, which becomes more of lateral weight shifting. And then you'll come up to kneeling, where your base of support becomes smaller. And that brings you to half kneeling. We use this a lot, but this is a very sophisticated position because you're rotating. And then from here, you load onto the feet, which are the smallest base of support that you can use. And that is a developmental progression that takes about a year to occur in a normal infant. But you can see how the movement, like especially something like this extension, is something that we use in classical Pilates, like a swan, where you could use the arms for support, you could not use the arms for support, but you're elongating and extending at the same time, as well as even something more higher level, which may or may not be something I would do with a child, but taking this into like a side kick, where you need to have your body weight extended onto that side, as well as using, you know, a much more complex series of movements. So that's the developmental progression.
And how do you integrate these principles with the Pilates repertory on the reformer? You use the reformer mostly. I saw you have a chair too, but
yes, I do. I use the reformer, you know, 90% of the time, I'd say, because I can just do so much with it. When I'm using the reformer, I do a lot of different things. Often I'll have somebody, now we might want to show Henry. I can discuss this when I see Henry. My glasses. Mm-hmm. Okay, so this is Henry, who is a 4-year-old boy. And this is something very typical that I do on the reformer, use the box that also shortens it up. But what I'm looking for here is because he has an ankle issue, I'm actually really trying to get him to dig his heels into where the box meets the carriage and get translation of his tibia over his foot. That is something we need for typical gait. And you could see that his toes lifted. And that's also what I'm looking for. It's a foot reaction that is a dorsiflexion reaction. There it is again. That is necessary for balance and coordination. Here he's doing chest expansion. And you can see this is a child doing chest expansion. I have him weighted down with a sandbag so his legs don't fly up. But he occasionally can maintain the posture and sometimes he can't. Now this is one I really like doing standing splits with somebody who has foot issues, because I can activate, what I'm asking him to do is to activate the lateral aspect of his foot. Like I'll say, shift the weight to the little toe side of your feet. And you can see that he's in and out of alignment. He tends to hyperextend his knee. Here he's feeling it a bit more. He's got a better form. The knees are slightly flexed. And I'll come in and I'll give a tactile cue to tell him, this is where I want you to push down. So this is, you know, in a tiny nutshell, this progression happened over a course of maybe 20 minutes. So those are some very typical things I do on the reformer.
How did you see that that learning played out in his gait or in his walking when he wasn't on the equipment?
Well, most recently, so his left side is the affected side with the club foot, which he has limited dorsiflexion, and the foot is kind of held in somewhat of supination. But it's very hard to balance on a foot that doesn't have all the foot reactions available to him. And most recently, he's able to hop on his left foot, which means he has enough force generation to get off the ground, as well as land and adapt the foot to the landing position. So that's huge for him. And he comes in the room and he just wants to hop all over the place. So he definitely integrates what he learns here into his everyday, movements. And both he and his parents are very happy with the outcomes.
It's so brilliant how children, you can create the proprioception shifts, the sensory shifts, and how it affects their motor control without them really you're not telling him when he's walking around your room how to push off his foot or where to stand. It gets integrated after the movement experience into their everyday life without thinking about it. It's like automatic for them.
Well, that's how we function. Proprioception, it's an unconscious sensation. We don't think, oh, my arm is up or down. But I would want to reiterate that is the beauty of the Pilates too, is like they are learning that while they're doing the exercise. And even though they don't, they may not say, oh, wow, I really feel that. Sometimes they do. But often I can kind of see their facial expressions like, oh, okay. Like they're feeling something different. They're having a new experience internally. And the way I use it, what first appealed to me was a very traditional physical therapy activity is if someone cannot move in gravity, you take them out of gravity and have them learn the movement pattern, which is what we do here. When I put somebody in supine, they're out of gravity. And then once we do the activity, then I take them and I put them in gravity and let them practice it as we would in our normal day. Because the ultimate goal is to be able to function well and maintain your posture within gravity. So it all just flows together really nicely.
It's wonderful to see the results, the changes, to the children, even when they're not doing it perfectly. Like a Pilates teacher would think the perfect chest expansion, you have to be this, and pull and breathe in a certain way, like all those things that we learn in the teacher training. And we try to get the clients to do that. You're not cueing them in that way. Right? You're cueing them more through their feeling of what they're feeling on the equipment, how they're pushing and pulling and they are kind of a little all over the place, but then they get off and then they're moving differently.
Right. And I may cue them depending on what I'm observing. Like, so when he's doing that, I may say like, squeeze your bottom, squeeze your bottom more. Or if the child already has the stability of the hips, then I might go up to the shoulder girdle and say, squeeze with the backs of your shoulder blades. I'll focus in on what I think they can do. As I mentioned before, I'm going to start with the very basic and build them up from the bottom, rather than shooting for something that's impossible and they never quite get it.
Well, it has to be
Christine,
fun.
Christine, what guidelines do you have for Pilates teachers who may be participating in this webinar or watching it on YouTube later? What guidelines do you have for people who are interested in working with children? Is there a place where people can learn these skills?
Technically, right now there is not. But I would say if you're a Pilates instructor, I would get as much information about the child's condition as you could possibly have, so that you have an understanding of what the issues are. And I would get, there are often reports that exist, like from the physical therapist, from the doctor, the orthopedist, the neurologist, whoever the child may be working with, This you would access through the parent. The parent is your main source of information. But I would start very rudimentary. I would start with the basics and get a feel for what can they do. Can they have mid-range control when doing a very simple flexion extension exercise on a reformer? What type of body awareness do they have? What do they respond to? And I would move slowly. I wouldn't jump into it. I would tend to move slowly. And you can also collaborate with some of the existing practitioners. Like, often I will refer out a child to a Pilates studio because they don't need me anymore. They need someone who's going to work with them on a regular basis, maybe multiple times a week. And then we go back and forth about what the goals are if they're, the child's making progress and they need to move ahead. So I would use a lot of the existing resources that the child and the family has to get as much information as you could.
You really emphasize family, Christine, how it's not just the child, but it's the family. And I'm curious now with COVID, how did you deal with the telehealth, as you would call it? We call it a Zoom session. Did you use that, and how did you use that, and how did that influence or change your work moving forward?
Well, ironically, the weekend before the shelter in place, myself and the other therapists that work with me, we all did a webinar on doing telehealth with children. So that's, at least we had a background in it, because up until that point, telehealth was not used much at all. I rarely used it. Occasionally, if I'm working with someone who lives in another state or another area, we would do a FaceTime meeting or something like that. But I would say, so it's shut down on Monday. Tuesday, we're doing it. We're in it. And some of the people really took to it. Other people no, because in some cases, looking at a screen is not the same thing as being on a piece of equipment and being able to feel the resistance and do all the, the physical work. And also for me, the hands-on. And also for me, what I've discovered is, Zoom is not three-dimensional. So everything, I'm looking at everything like, what is the shape of it? How does it look? How does it move? You can't see that on a video. But some of the diagnoses that I work with that do translate to telehealth are working with infants, because in the time of COVID, it's unique that I have both parents there at the same time. Normally, scheduling is very difficult because either one or both of the parents are working, and I might get a nanny, I might get a grandmother, which is also good because they're taking care of the child. But I've had some really wonderful experiences with both parents at home, and they are very attentive to what's going on. And it becomes more of a coaching. So I'm actually coaching the parent on, okay, put your hand here, push down harder. I because I'm a New Yorker, I can give very direct instructions. And I feel like that direct input verbally is what you need to use in order to get your point across, because there's not a lot of subtlety on a video.
Following up on my previous question, if a Pilates instructor is interested in doing some continuing education, and yet they're not a clinician, they're not a physical therapist or an occupational therapist, do you have any recommendations on how someone can get more skills in the neurodevelopment that you have?
Well, there is, the neurodevelopmental treatment that I do, you do need to be a licensed practitioner to do that. But there's probably resources that you could look into. I would there is a website for the Neurodevelopmental Treatment Association. You could start there. They have an office you could call and ask, what would I do to learn this method or learn more about it? And understanding developmental movement. I think in the dance world, there are people who have explored developmental movement. I don't know the names off the top of my head, but if you're in the dance world, there are people who have looked at that. And I would just go in, and you could do a Google search on developmental movement. But the way I learn best is through my own body. So even when I'm training a parent who is not a Pilates instructor, but is not a professional, is to get down on the floor and have them do the movement. Like, could be, having somebody go from laying on the floor to sitting up. Like there's a way of doing that we're not even conscious of. But physical therapy at this time, I when I did it, it's a bachelor's degree and then a licensure. But at this point, it's moved on to having a doctorate in physical therapy. So it's a lengthy educational process. And with that, you have time to learn repetitiously the same concepts over and over, and the different applications of them. So it's something the person would have to have a real interest in to pursue it.
Yes, I think that Bonnie Bainbridge Cohen, an occupational therapist, has created body-mind centering, which is the curriculum is accessible to all, and it's going through the movement practices of developmental movement.
Yes, and similarly, if a physical therapist comes to me and they want to know more about Pilates, my instruction to them is go do Pilates. Experience what it is. I can't tell you what to do as much as you will incorporate it into how you move and your understanding of movement. I think that is the better way to learn Pilates.
Christine, I'll share with you a little something about developmental movement that I kind of use in my own mind when I'm working, especially with a newer client, or a client who maybe had an injury, And what I do in my mind is I actually kind of look at how they move. So if a client is older, a little kyphotic, and they're very uncomfortable lying on their stomach, it's not comfortable for them, and they can't even like lift their chest at all, because they're stuck in that flexion. So in my mind, I go, okay, they're 0 to 6 months. You say, and then, so then I say, okay, they're at 0 to 6 months in there. It's like my assessment. And then from there, I go and design the movements to bring them from 0 to 6 months to 6 to 8 months old. It's like, it's so, even though it's an adult, I like to use those little platforms as a guideline for myself. I don't tell the client, you're 0 to 6 months. I don't tell them that. But it's a way to kind of have a movement assessment, the pattern in my mind, and then from there see them progress. And then I'm very happy when I get them up and they're actually walking really well, because now they're they're more like 2 years old.
That's great. That's a great application of it.
Yeah, so it's very fun. Your experience with the telehealth, I know you expressed the environment being really informative to you, seeing the child in their home with the other children, and the interactions, maybe the pets and things, and versus, being in your studio.
Right.
Did you feel that the children were more focused in the environment of your studio, or, how did that change in terms of their awareness and ability to concentrate?
Well, I would say, so one of the benefits of telehealth is that I get to see the environment that the child's in. So I can, I might be, working with the parent and the child, and we need some kind of prop or something, and I'll go, what's that pillow over there? Like, grab that pillow, we're going to use that. And I can work with what's existing in the environment, which I think makes the parent feel like, oh, I can do this. I have the ability, I have the equipment. And sometimes I will do telehealth from my office, where I can hold up a piece of equipment and go, like, do you have something like this? Do you have something like this in the house? And then they go get it, and we can use what they already have. They don't have to go out and buy things. You can set up things like obstacle courses and using the home environment. Now, I will say that I can achieve much more in my own clinic, because I am holding the space I am holding the container for which the activities occur. And I often, I used to kind of compare my physical therapy practice more to a psychotherapy practice. Like, I am with you. I am with you this entire time. I'm not looking around. I'm not going to see somebody else. I'm not answering the phone. I am like white on rice. I am just constantly observing you, moving with you, making it, making sure that everything is safe. So it's a completely different environment. And I think one of the underlying tenets of my practice is that the patient trusts me. So I engage with them to create a trusting relationship where they'll allow me to do something that's out of their norm. They will allow me to take them somewhere that's out of their comfort zone. And that is, to me, more of an interpersonal relationship that's really hard to do. And I think with regard to telehealth often works better with people you already know rather than a new client. It could go either way, but there's something to be said that you already have an idea in your head. You physically touch them. You kind of know what the issues are. So right now, often I'll have somebody come in for an initial visit, and then the next visit I'll do telehealth to get that environmental thing, get the parent working in the environment, and then see, is telehealth going to really work, or is it something that we just do intermittently?
I would think it'd be important for their home program too, to keep up their own home practice.
Yeah, absolutely. Having a designated space, using, I think having a certain routine, even a time of day, because getting people to do home programs is challenging, very challenging.
Christine, over the decades that you've been working with children and with adolescents, have you noticed a change, general trends in terms of their physicality, their well-being, their competence? Are you seeing trends in children's health?
I do see trends. So, and this goes back to the torticollis issue, so in the first 15 years of my practice, I literally saw 3 cases of torticollis. And now I see 3 a week because of the child not being positioned in prone and not really going through what I would call a normal developmental sequence. So because babies sleep on their back and they sleep for extended periods of time, they're really activating their extensors, 16 to 18 hours a day. So often that is why when I ask someone to do a movement into flexion, they go into extension, because that is where they go. They go to the dominant movement. And, they say things that wire together, fire together. So I see a lot more developmental issues. And even things like with parents, they'll say like, oh, he likes to stand. The kid's 4 months old. I'm like, yeah, 4-month-old babies do not stand. To me, standing is you've gotten yourself up, you've pulled yourself up, and you've figured out how to become vertical in gravity. That is standing to me, not taking a stiff person and putting them on their feet. So I have to kind of backtrack a bit and educate the parents on some of these normal development things, but it does translate. And now, with so much with remote learning, computers, gaming, I have children who I see who will come in with neck and back pain. Well, 8-year-olds don't normally have neck and back pain, but they do now. So it's definitely an issue. And often we'll go over, positioning, like what kind of chair are they in? Should they be standing part of the time? Using alternate positions for them while they're doing remote learning. So
we have a question, Christine, from Esther. She asked, Christine, could you say that removing gravity and using closed chains is also possible without all this wonderful Pilates equipment? And did you do this before you started integrating Pilates? And did you use a lot of wheels?
I did not use a lot of wheels. So before I used Pilates, I basically used my body as the resistance, or I would bring in a ball or, a roller or something to give the child some stability and or mobility. That's why balls are useful. And I use a lot of like egg-shaped balls. I call them peanut balls because they're very stable. They're much more stable than a round ball because you're only going in one plane of movement. So, I mean, my office is filled with things, toys and things that move and things that make you stable. But in terms of doing it over a long period of time, it takes a toll on your own body because I'm physically lifting the equipment around. Here, my assistant has brought me a peanut ball. These are great. I love these because you can control a lot of motion. You can do a lot of active flexion and extension on these things. You can straddle it. Everything I have has many, many uses. I don't think I have anything in here that only does one thing because you just wouldn't do that because there's too many things to have. So in answer to the question though, I mean, literally I had to provide the resistance and using my hands and my body. But at a certain point when I was around 40 or so, I had a bulging disc and I couldn't do it anymore. So the beauty of the equipment, and for me, because I do this all day, every day, investing in the equipment made perfect sense to me. And I have other devices, like I have a light gate that is a gravity assisted thing that you use to do gait training on a treadmill. Like otherwise I was trying to hold up the child, move the feet. It's almost impossible. So for someone who is a pediatric physical therapist who does this all the time, well worth the investment.
Christine, would now be a good time to tell people how they can get in touch with you if they have further questions or would like to schedule a consultation?
Sure. I have a website. It's christineegan.com. And I also have a Pilates Kids website that's pilateskids.com. And I'm happy to answer any inquiries that people may have about other people that they might want to consult about. And that's something that perhaps we could do by telehealth is, we work together with the family to kind of determine what we could possibly do together. But I'm happy to consult with other therapists, instructors, parents. That'd be great.
Super. While this slide
comes out, we'll be able to communicate this to a wide range of people. I think having the book available will be wonderful for people to see what we've done.
Yes. While this slide is up, Hillary, we'll just note that the next Pilates Applications for Health Conditions webinar will be in a month from now on Wednesday, October 14th. And Kelly Kane, who's a movement maverick and the co-director of the Kane School, will be speaking about her case report, which is Aging Well with Pilates.
We go from the children to advancing age.
Span the whole lifespan.
Well, thank you, Christine. It's been wonderful.
Thank you. It's been a pleasure. That's it.